Good afternoon, everyone. Thank you for
Can you
joining
hear me?
early. Yes, I can hear you.
Yeah, please go ahead. Go ahead.
Oh, okay. Thank you very much, sir. Uh, Good afternoon, everyone. You are welcome to our April webinar of the Guild of Pediatricians in Private Practice. This is a monthly meeting that we hold to interact with each other and then to learn new ideas and to learn new concepts. And today will not be different from our previous meeting. So I'll yield to the president of our society, Dr. Letu, for his opening remarks before we get the meeting going. Thank you, Dr. Letu. Over to you, sir. Dr. Letu, over to you, sir.
Sorry, I got disconnected. Okay, good afternoon all. Welcome to this month's webinar. And let me first start by thanking Professor Grange, who's joining from America, Dr. Mbolaji Lawal, our emeritus president, and everybody here present. So today, on behalf of the Guild, I will have the pleasure of welcoming some of us warmly to today's webinar. We are delighted to see such a strong participation, and we expect that the numbers will grow, which reflects our shared commitment to continuous professional development and excellence in pediatric care. The topic for today, when joints speak, recognizing rheumatic diseases in children, is both timely and clinically significant, particularly when we know that rheumatic diseases in children, they are very often subtle in presentation and easily overlooked, and potentially debilitating if not properly identified and treated early. So today we have the pleasure of having Dr. Ayodele Faleye, whose experience in pediatric rheumatology will undoubtedly enrich our understanding and sharpen our clinical skills. So I encourage all of us to listen carefully, ask questions, and engage the speaker. And at the end of it all, we shall be better for it. Thank you very much, and I hand over to Dr. Odushote.
Thank you very much, sir, for your opening remarks. So I'm going to yield to Dr. Temitope Okoro, a senior registrar in the Department of Pediatrics and Child Lasso, to moderate this meeting. Over to you, Dr. Temitope Okoro. Thank you.
Thank you very much, sir. Good afternoon, everyone, once again, and welcome to today's section of this webinar. So shortly, I'll be introducing our guest speaker to us. Dr. Ayodele Faleye is a consultant and a pediatric rheumatologist at the Lagos State University Teaching Hospital, Ikeja, Lagos, Nigeria. She had her undergraduate training at the Ladoke Akintola University of Technology in Ogbomoso, pediatric residency training at LASUT, pediatric rheumatology training at the University of Cape Town in South Africa, and Alde A Children's Hospital in Liverpool. She is the pioneer of pediatric rheumatology. Hello? Okay. She's the pioneer of pediatric rheumatology, the first consultant pediatrician in the field of pediatric rheumatology, West Africa. She's a fellow of the Faculty West African College of Physicians, Doctor of Medicine in Pediatrics, and a Fellow of Pediatrics, National Postgraduate Medical College of Nigeria. She's currently the president of the Pediatric of the African League Against Rheumatism. She won the award of a clinical research fellowship organized by the Pediatric Rheumatology Society in 2021, and also the Phil Robertson Global Scholarship in 2023 for American Rheumatology Congress. Our hobbies are cooking and reading. Ladies and gentlemen, let's welcome to the floor Dr. Ayodele Faleye. Please, before she comes in, any questions that we have, we can type and put it on the chat box. Then after the presentation, we'll be given the opportunity to unmute and also ask our questions. Dr. Faleye, you have the floor, ma'am.
Yeah, thank you so much for that kind introduction. Good afternoon to the medical elders. Good afternoon to all my colleagues, and good afternoon to the GP, IP chairman, and the chief coordinator. Thanks for inviting me. I'll put this on slideshow. So the objective of this talk is to identify the key clinical features of pediatric rheumatic diseases, also to look at the outline, to outline a basic approach to childhood arthritis, and also to recognize red flag symptoms and signs when we see children with joint symptoms. Now, here is my outline. I'm going to talk about when do we suspect pediatric rheumatic. I will introduce all to pediatric rheumatic, and I will also like us to know when we are to suspect a rheumatic disease in a child, clinical approach to a child with childhood arthritis, basic investigations. Why is it important to know about pediatric rheumatic diseases? Then we summarize and we entertain questions. Now, pediatric rheumatic diseases, I will use the term PRDs throughout this presentation. They are mostly chronic immune-mediated musculoskeletal and connective tissue disorders. It occurs in children, women, individual 18 years and younger. Most of these diseases, they are of autoimmune origin, like lupus, JIA, lupus, juvenile idiopathic arthritis, juvenile dermatomyositis, and musculoskeletal complaints are key features like joint swelling, joint pain, redness, when we mention most of these diseases. But each disease entity has its own signs and symptoms. And then also we have a criteria that we use in diagnosing these children. So most of them are associated with joint symptoms, but they can involve other organs in the body, like the eyes, the skin, kidneys, the heart, the lungs, the brain. Almost all organs could be affected. So some of the autoimmune diseases are actually multisystemic. I have mentioned the examples. The burden of PRDs is not this it has been estimated that 6 to 7 million children have been affected worldwide, and 10 to 20%. Sorry, I can't just see my screen again. Sorry. Okay, I'll share again. Please, can you see my screen?
We are seeing it. It's obvious to us.
Okay. And it's not obvious to me here. Okay, I will stop sharing, then I'll share again. Okay, please, can you see my screen now?
Not yet, but we can see that you are making it. Okay, we can see it now. So
okay.
To put
So it's been estimated that, thank you, sir. So 20%, children with rheumatic diseases accounts for 10 to 20% of the total burden of rheumatological disease that we've got. That means the other 80% are for the adults. So in the United States, it's been reported that there are up to 294,000 children with rheumatic disease being diagnosed with rheumatic diseases annually. In the United Kingdom, 32 to 42 per 100,000. Also, another study from Singapore reported 57.8% of referrals to a pediatric rheumatology clinic to be that of pediatric rheumatic diseases. Currently, we do not have figure for Nigeria, but my trainer and my mentor, Professor Adelowo, published an article whereby he reported 57 cases that were seen over 5 years in an adult rheumatology clinic in Lasut. Now, 2 years ago, we also had we had a manuscript whereby we summarized the first 90 whereby we reported 90 cases that were seen in our clinic in Lasut, in a pediatric rheumatology settings in Lasut, within a period of 2 years. That was between 2022 to 2024. The articles are online. The history of pediatric rheumatology in Nigeria, the present and the future, we can access this online. Then also we have case reports from Nigeria on lupus by Lucian et al. We have case reports on maybe systemic sclerosis. Other parts of Africa too, we have some cases of PRDs that have been reported, like in South Africa, in Kenya. They have all had a case series and case reports on pediatric rheumatic diseases. Recently, the Pediatric Society of the African League Against Rheumatism reported 301 cases of juvenile idiopathic arthritis via a registry, in which we had 4 to 6 countries in Africa that participated in that study. We are still recruiting data, and the registry is still active. Now, clinical features of rheumatic diseases. How do we clock them? What are the things to look out for? What will the patient tell us? Usually they present with persistent joint pain of greater than 6 weeks. Most times when children present with a joint pain of less than 6 weeks, we may not really look at it from the perspective of being chronic. And one may not be thinking about a pediatric rheumatic disease. One may be thinking of maybe something very acute like septic arthritis and some other causes. Now, also joint swelling, very significant. I will discuss that later. Then joint stiffness, especially in the morning. A child that wakes up from bed, but wakes up on bed, but is unable to jump out of bed. And when they do so, they are limping for at least 1 hour during the day before they get better. Then also difficulty with daily activities, a child that is unable to walk, they are unable to button up their shirt, they are unable to comb their hair, they are unable to carry a bucket of water, they are unable to climb the stairs. The quality of life of that child, you can ask questions related to that. Day-to-day activity of the child could be very difficult. Most importantly, we also need to ask questions around, we also need to ask for constitutional symptoms, which are fever, fatigue, weight loss, and appetite. And this is common to most of our patients. They do present with a low-grade fever, most times daily. The child feels unwell, and they could give you a history of inability or loss of interest in schooling. The child is so weak, he or she is unable to go to school again. Then skin rashes, hair loss, fatigue, red eye, gritty sensation in the eye. Like the way to ask the question is, do you feel as if someone has poured sand inside your eye and you need to clear it most of the time? Some of them will say yes to this because some of our patients are prone to uveitis. Then also Raynaud's, when it is very cold or when they dip their hands in the freezer, top of the finger become bluish in color, bluish discoloration of the tip of the fingers. That's Raynaud's. You want to find out if the child has been expressing that. Also, Zika symptoms, dry eye, dry mouth. These are some of the things to ask the patient. Oral ulcers, nasal ulcers too are very important questions to ask them. When I start discussing examples of pediatric rheumatic diseases, we will be able to appreciate why we need to ask all these questions from the patients. Then also difficulty with swallowing. A patient with juvenile dermatomyositis may present with this. They could present with a recurrent sore throat. Then others that we have seen, seizures. The presentation could just be that this child has been having recurrent seizure, loss of memory, chest pain, chronic cough greater than 3 weeks. It could be a rheumatic disease. Then clinical features of rheumatic disease could be anything. And that is why we need to have a high index of suspicion. In fact, we've had patients that do not even fit into any of the criteria that we've been using to diagnose them. So how do we approach a child who has come into the consulting room with a joint swelling? We can only say the child has arthritis when there is a joint swelling. Joint pain is different from joint swelling. When we say joint pain, that means we are talking about arthralgia, and it's quite different from joint swelling. When it is not swollen, then it is not arthritis, because we receive consult sometimes and we'll find out that a diagnosis of JIA has been made, but patient of juvenile idiopathic arthritis has been made, but patient does not have a joint swelling. So likely that patient doesn't have juvenile idiopathic arthritis. Once there's no joint swelling, then the patient does not have that. Now, we say the joint is swollen, painful, there's loss of function, it could be erythematous, then we start talking about arthritis. All 5 cardinal features of inflammation should be present in a joint before we say a child has arthritis. Now, the child has presented with the joint swelling. We have to establish this. Is this acute? Is this chronic? When it is less than 6 weeks, we start looking at the acute causes, and I will show us this later on. Then when we say it is chronic, when you think about, when we say it is chronic when it has been persistent at least for 6 weeks, and that is a chronic arthritis. Then we also need to ask ourselves, is this inflammatory? Is this non-inflammatory? It is inflammatory when it is worse in the morning, when the child limps in the morning and gets better later during the day. It is non-inflammatory when they have gone to school, they've been everywhere, but they experience the pain in the evenings. That is what we also call mechanical pain. It's mechanical or non-inflammatory, but when it is inflammatory, there's joint stiffness, and that is why they are stiff in the morning. How many joints are involved? Are they single? Is it a single joint, or are there multiple joints that have been involved? All this has to be established. It's going to lead us to the diagnosis. Then we also need to look beyond the joints pain and swelling that the child has presented with. Is this only musculoskeletal illness, or this child also has lymphadenopathy, child is pale, has hepatosplenomegaly? Well, then the approach to will be different. That means it is beyond the musculoskeletal system. So we need to also look into this. Now, acute causes, we can think of septic arthritis, acute rheumatic fever, reactive arthritis, viral arthritis, sickle cell anemia. But when it has persisted for more than 6 weeks, we can start thinking about maybe TB, fungal infections, juvenile idiopathic arthritis, and connective tissue disorders. Now, the pattern, the presentation, the duration is very important when it comes to clerking this patient. History taking is very key. Then also, like us to know, when it comes to arthritis, we need to be very careful because that will create a form of a diagnostic dilemma. We have had children who presented with dactylitis, as seen in this picture in our clinic, who ended up with a diagnosis of lymphoproliferative disorder. For me, for us in rheumatology, we would have said this child has polyarticular juvenile idiopathic arthritis, but we're very careful, especially because we know JIA is a diagnosis of exclusion. The child came in with a pallor, but the child was pale. So we had to refer to the oncologist to at least evaluate the child before we continue. And they did a BMA. It was actually a lymphoproliferative disorder. So history taking is very important. Physical examination, who am I seeing? How has the patient presented? Then laboratory investigations. We can do the ancillary ones. I will mention those ones later. What to do, the investigations to do before we refer to the rheumatology clinic. So very important, we also need to consider the age of the individual, the age of the child, the gender. When a girl is presenting with a joint pain, joint swelling that has persisted for more than 6 weeks, then we need to look at connective tissue disorders, among all other things. Then also onset and duration of pain. I think I have discussed all this. Now, also, we need to look out for red flag signs. In our clinic, we normally, once a child gets to the door of the clinic and the child is crying, the child is in pain, excruciating pains, not likely to be a patient with rheumatic diseases. The pain with the form of, with the autoimmune arthritis that we treat is usually dull ache. They don't cry. The only thing is that When they come into the consulting room, you find out that some of their joints are swollen and they are unable to make use of them. Like little children, when they are playing with toys, you will see them avoiding a particular hand. They don't want to use it to hold an object. Or when they are walking, they are limping, but they are able to play. But when a child comes to the clinic and the child is crying, the mom is telling you that or she doesn't sleep at night, I think that patient should first go to the oncologist for thorough evaluation before coming back to the rheumatology clinic. Then also fever, malaise, though I have mentioned that our patients could have fever, but we need to pay special attention to this because if we can be very thorough with our evaluation, we'll be able to arrive at a correct diagnosis because we mustn't miss it from that point. So bone or joint pain with fever, very important too. Then we know that we are in a sickle cell, we are in a country in which we have so many patients with sickle cell anemia. So we have to have high index of suspicion for this too. That means we do hemoglobin electrophoresis before we can say, okay, this is a rheumatic disease. We must have excluded the common causes of joint pain. Even our viral markers, we must have done them. So refractory or remitting pain, persistent night waking, then these ones are red flags. They are beyond the kind of joint pain and joint swelling we do see in rheumatology. So our general examination is very important, like I mentioned. Pallor, lymphadenopathy, a patient with rheumatic disease can have lymphadenopathy, especially lupus. They can have lymphadenopathy, they can have hepatosplenomegaly. Even a patient with systemic onset JIA, they can have lymphadenopathy. So we have to examine well, and we have to know the investigations to do to exclude all the cases before we now arrive at a definitive diagnosis. Now, very important, I mentioned systemic examination. It will be very important for us to know how to examine the musculoskeletal system. So this is PGALS. We have it on Apple Store. We have it on Android. We can download it. They're just a simple tool that we can use to examine the musculoskeletal system within 5 minutes in the clinic, where we check almost all the joints, pediatric, the gait, the arms, the legs, and the spine. We have to check, is there any reduced range of movement in any of the joints in the body? But I wouldn't want to go into details because we have limited time for this session. So let's quickly look at the common pediatric rheumatic diseases. The most common one is the juvenile idiopathic arthritis. Now, it's a diagnosis of exclusion. We can diagnose a child with a juvenile idiopathic arthritis if the individual is less than 16 years and the arthritis has lasted for at least 6 weeks. The individual is less than 16 years and the arthritis has lasted for at least 6 weeks after excluding all other causes of joint swelling. Now, different types. We have the systemic one. We have what we call oligoarticular. We have polyarticular. We have enthesitis-related arthritis. We have undifferentiated arthritis. I will just say a few words about each one of them before we move on. When we say oligoarticular, what we are saying is that the maximum number of joints that have been affected are 4. You have 4 joints that have been affected and they are large joints. So we don't talk about oligoarticular when there is arthritis of the fingers, of the small joints of the hands, of the toes. No, when you talk about oligoarticular, you're talking about the knees, the ankles, most commonly. Then also it's more common in girls than in boys, and they are at risk of uveitis. That means that a child coming with 1 or 2 joint swelling can also have poor vision. So, and that is why we normally ask them when we are clacking, do you have any history of red eye, gritty sensation in the eye, poor vision? Even if they don't have, they still need to visit the ophthalmologist because sometimes they are asymptomatic. So when a child is diagnosed with oligoarticular, even all the types of JIA that we've got, we normally send them or refer them to the ophthalmologist for a slit lamp examination. Very important. And then when we say polyarticular juvenile idiopathic arthritis, we are saying that there are 5 or more joint involvement, usually symmetrical. It's rare for us to talk about polyarticular arthritis when you have asymmetrical involvement. No, it has to be both sides. If the middle finger of one hand is affected, then the other one should also be affected. Then it affects both the small and the large joints. And that is the difference between polyarticular and oligoarticular. They do not have fever. Just like in oligoarticular, they don't have fever too. Otherwise, well child who is walking into the consulting room with just joint that has lasted for more than 6 weeks, but the type of joint that has been involved and the number differentiates the two. Now, when we talk about systemic onset JIA, those ones usually have fever. They have joint pain and swelling. Their joint involvement is usually the large joints. Then they do have fever and they do have a pallor. They are usually pale. They have lymphadenopathy. They have serositis. They can have pericardial effusion. They can have pleural effusion. They are very sick children, unlike the other two. Those ones, we usually see them in the clinic. They don't need hospital admission, like the systemic onset juvenile idiopathic arthritis. So those are the 3 common types. So I wouldn't want to go into psoriatic or enthesitis related arthritis because of our time. Now, these are the pictures we can see this child with, this is a picture showing oligoarticular JIA, the right knee of this child and also the left ankle of this child. And I intentionally put this here just to remind us that whenever we have a child with 1 to 4 joint swelling, we should give them a referral to the ophthalmologist. And sometimes even uveitis that the ophthalmologist could detect could even precede joint swelling in these children. Sometimes it is the ophthalmologist that will see the child, send them to and in the course of managing them, maybe after 2 years, one day, they will now come in with the joint swelling. So that means that they can first have joint symptoms. So we have to have high index of suspicion for this. Then also this polyarticular idiopathic arthritis, we can see that this boy has a fixed flexion deformity of both wrists of the proximal interphalangeal joints. He is even unable to extend even the distal interphalangeal joints too, because his symptoms was dated back to 8 years before he came to clinic. The symptoms started at the age of 6, or at the age of 14. So he came to the clinic, he was completely disabled. Now, very important with the systemic onset JIA, they will not respond to antibiotics, no matter what you do. And that is one thing. When you have a patient with high-grade intermittent fever that is not responding to antibiotics, and you have done everything, you've done blood culture, you've done urine culture, you've excluded TB, you've excluded viruses, you've excluded excluded fungal infection, but yet the child is not getting better. We can look at the TPR chart. If we have this kind of swinging fever pattern, it is suggestive of systemic onset JIA. Then when they have that high-grade fever, they do have this characteristic rash that we call the salmon rash, though it's very difficult to appreciate it in blacks. So complications that our patients with juvenile idiopathic arthritis, they can have uveitis. I've mentioned this, leg length discrepancy, flexion contractures, disability. They become completely disabled. Then psychosocial issues, school absenteeism, chronic pain syndrome. Then those with systemic onset juvenile idiopathic arthritis, they are at risk of macrophage activation syndrome, which has a high fatality rate. It is a rare emergency in rheumatology, whereby they have high-grade fever, they have jaundice, they start passing dark-colored urine, they can have renal failure, and these are very sick children. We don't want them to develop this complication before we refer them or before they are being diagnosed of the disease. Now, how we give an overview of juvenile SLE. SLE is also an autoimmune disease, is severe, chronic, life-threatening, is multi-systemic, is different from JIA because JIA, the first two types are they do involve the joint with no organ involvement, except for the systemic onset JIA, in which we have organ involvement like the heart, so they have pleural effusion. I've mentioned all this earlier. But these ones, they do have autoantibodies. We have autoantibodies in JI2, but they are different from what we see in juvenile SLE. But I wouldn't go into that. Probably there will be another time where the major topic will be juvenile idiopathic arthritis, or we have a topic on juvenile SLE. I'm just giving an overview. So we say it's juvenile when they are less than or equal to 16 years. Though this varies in some other countries, they will say 18 years until they are 18. They are still juvenile before they go through transition to the adult side. So it has protein manifestation. SLE could be anything. Could be anything, but we have diagnostic criteria. I believe we must have come across brain MD where about cystitis, oral ulcers, arthritis, photosensitivity, ANA positivity, renal involvement, blood dyscrasias like anemia, lymphopenia, leukopenia. In this, they can even have pancytopenia, thrombocytopenia. We have a criteria, but looking at the symptoms, it could be anything. It may be a child that has been coming to the clinic all the time because of headache. It may be a child that has been coming to the clinic often because of just recurrent seizure. And when you examine, they don't even have arthritis. They don't have joint pain. All they have is that they've been having recurrent seizures. We've seen quite a lot of these cases, and they did not even fit into the criteria. But when we did a serology, we found out that they are actually patients with SLE, and we're able to help through commencement of medications. They are now very calm. So I am reading this here that we have unusual presentation. Not all cases of SLE will have a malar rash. We are always on the lookout for that, because we see that in the textbook. Oh, SLE, malar rash. Most of our patients will not present with malar rash. They may just have constitutional symptoms and recurrent anemia. Then also we have had a girl before who had recurrent anemia, and she was a sickle cell patient. They thought she had autoimmune hemolytic anemia until they invited the rheumatology unit. We found out that she had discoid rashes on the face. We reviewed her, asked her to do investigation. It was actually a case of GSLE. She had 13 pints of blood within 6 months. So also chronic cough. When you have excluded TB, you've done chest X-ray, you've done everything, MAN2, you have evaluated, you've excluded viruses, you've excluded, I said chronic. You won't even be thinking about viruses again. That means it has lasted for more than 3 weeks. No, you know this is not bacterial infection. Let's think about lupus. It may just be lupus presenting with chronic cough. We've had that in clinic. The patient now eventually did high resolution CT of the chest, and it was actually interstitial lung disease. That was how we also took samples for serology. It was actually a patient with lupus, but just chronic cough. She was on examination findings, nothing. There was nothing. So we have unusual presentation, unexplained weight loss. Someone is just losing weight. People feel it's HIV, or probably they feel it's malignancy. But yet they've run all the tests. They are not so sure. Then we should think about rheumatic diseases. Then unexplained bullous eruptions too. Very important to think about SLE, especially when we are not winning. Now, this is the girl, the sickle cell, the girl with a sickle cell anemia that had a discoid rash on the malar region of the face before the rheumatology clinic now reviewed. Then also, this is another 12-year-old girl with bullous eruption. We thought had Steven Johnson syndrome, but it was too late before we thought of lupus. We actually lost the patient. Now, when we review patients, or one of the parts of the body that we should check are the hands, especially the palmar surface of the hands. This is vasculitic rashes. If we come across any patient with this is likely to be a patient with lupus. We have so many of them. especially in this environment whereby it takes so long before we have our investigation results. We have to rely on our clinical judgment to start treating that patient, because if we wait for serology, we would have lost the patient. So this is another girl with alopecia. I remember this girl came from Dr. Odushote's unit. He referred to the rheumatology unit. She had just cutaneous features. She has a hyperpigmented rash and alopecia. That was it. No organ involvement. She was otherwise well, except for this. And it was actually a case of GSLE. Now, I'll quickly go into dermatomyositis. It's also autoimmune, and it's a chronic inflammation of striated muscle and the skin. And that is why dermatomyositis, derma, skin, and myositis, the muscle. It's characterized by its perivascular inflammation of varying severity in multiple organ systems. And later they can develop calcium balls under the muscles, which we call calcinosis. So they present with proximal muscle weakness, which is usually symmetrical. And this is how it is. The child is unable to, like what I mentioned when we started, unable to comb the hair, unable to button the shirt, unable to carry a bucket of water. They can't even climb again. Most of them some of them, they have a hoarseness of voice, they are unable to swallow, and that is why they give them liquid diet. They are unable to swallow solid, because esophagus also has I think a percentage of striated muscle. They are usually weak, miserable, very miserable. They look miserable. They have characteristic rash. We call one heliotrope rash, where they can have shore rash. They can have what we call Gotron's purple. I will show us the pictures. Now, last year, we had a 2-year-old girl with a juvenile dermatomyositis on board last suit. She had this erythematous hypopigmented rash. It's also perihospital, which we call heliotrope rash. She also had the shore rash, where we females used to put our scarf around the neck. She had this. She took this picture after we started treatment, but this picture, she was at presentation. She was unable to even lift her head from, she had severe head lag. She can't control the neck and the head. You only lift her off the bed. She was unable to walk again. They have to feed her. She lost all the milestones. So we must have an index of suspicion for any child coming to us with inability to walk and inability to, and also skin lesions. Yes, skin lesions on the face, on the neck. You can have on the side. There are so many types of that a patient with JDM can present with. Now, I also mentioned Gotron's purple. In the dermatology clinic, when we think Gotron's purple is actually a what? Proximal interphalangeal joints are seen on the screen. They are usually erythematous. They look like plaques. So when we think that these, but actually these are Gotron's purple. Then beyond the metacarpophalangeal joint, one can see Gotron's purple on the elbows, on the knees, then even in the calcaneal region. This had a JDM with, when we palpated this, they were actually firm swellings in the buttocks and on the thigh. We requested for a radiograph, and we found out that they were actually calcium balls under the skin. So when we see all these, when we examine them and we find out that there are some firm lesions, this can also help us to strengthen our diagnosis of dermatomyositis. Now, for scleroderma, when we hear the word scleroderma, what it means is hard skin. The skin is hard due to excessive accumulation of collagen. And it's juvenile when it occurs in children, in individuals less than 16 years. Now, this is a 12-year-old girl that was seen in our clinic some times ago, who presented with this lesion on the thigh. This lesion that we are looking at on the screen was very hard. The first question one will like to ask the patient is that, did you have burns in the past, probably that healed? No, she said no, that she just woke up one day and discovered this, and it was initially not as hard as this, but later it became it was extensive, and then she noticed that that it was becoming more tough. Then also she had the same lesion on the fingers, and this led to contracture of 3 of her fingers. Now, that is about localized scleroderma. This is another type. We have this South African girl who presented with this lesion in duration of the skin, or that involved the frontoparietal region. And this lesion that we are looking at was actually indented. It wasn't an even surface. And this is actually a case of localized scleroderma. I'm just trying to show us pictures because it's possible to across these children, and it will just look like a spot diagnosis for us. Even the scalp, it was indented, and she had a alopecia, like a partial alopecia all over the scalp. Now, this is another one, which they have a loss of volume of one part of the face. Is also a type of localized scleroderma. We call it Pari-Romberg syndrome. I know we have had one before, also from the dermatology unit. Dr. Shota referred to the patient, but I've lost the picture. I don't know where it is. I will have shown her. So when we see any individual presenting with these two, we should have high index of suspicion for scleroderma. Now, when we say systemic sclerosis, we start talking about what we call sclerodactyly, tightening of the skin of the fingers. Is that tightening that led to the contracture? Coupled with this skin appearance, we call it salt pepper appearance. We have hypopigmented with hyperpigmented, and it was generalized. Yes, usually generalized. They do have it on the face, on the neck, on the trunk, with this kind of a presentation of the hand. By the time we see this, we should all first think about a rheumatic disease, especially scleroderma. Now, that's about connective tissue disorders, especially the inflammatory types of pediatric rheumatic diseases. I tried to quickly look at pain associated with hypermobility. Some children are quite hypermobile, and they are at risk of developing chronic pain, and they will always have a reason to visit the rheumatologist. Though they have an advantage because they can dance, they are involved in choreography, and they are involved in gymnastics because they are flexible, they are hypermobile, but they can develop pain, especially in the lower limbs. This is the scoring system that we use for them, but because of time, I will move on. Then for growing pains, the pain is in the muscles, not in the joint. Before a patient has growing pains, the patient wouldn't have presented with joint swelling, and no history suggestive of early morning stiffness. They usually complain later in the day, in the afternoon or in the evening, though it's been documented that some of them have the pain over the night, but the pain goes away in the morning. But if a child looks sick and the child is complaining about joint pain, that is beyond growing pain. We need to refer the child to the rheumatology clinic. Now, this is a very rare disease, but it's been said to be very rare, but we have seen 3 in Lagos in our clinic, where this patient presented with multiple bony lesions that were within the muscles in the body, and we noticed that they had bilateral hallux valgus. So the disease is actually called fibrodysplasia ossificans progressiva. Is an autosomal dominant disease, and we noticed that most of them, they had delay in diagnosis because they visited so many centers before they came to LASUT. And when we have this kind of patients, one very important thing to do is not to stick needles. Do not request for any investigations from them. Just refer to the rheumatologist, because every needle prick is a potential site for new bony formations under the skin. It's a genetic disease, so we should not prick them. Just refer to the rheumatologist, and then we take it up from there. So when we suspect this, our history examination is still very important, and then we can request for ancillary investigation to exclude common causes of joint pain. We need to do full blood count, ESR, CRP, urinalysis, viral markers. We should not rely so much on laboratory tests. And if the patient does not have enough to run investigations, please just do full blood count, ESR, and urinalysis, and refer to us. We are we are discouraging us from requesting for serology because most times patients would have done serology before coming to us, and we found out that usually they don't need that serology. Some don't need it, especially when the child coming with a persistent joint pain, no swelling, but has done all types of serology that we've gone in rheumat that is not even relevant to the diagnosis, so that we can help them to save their money. When we finally arrive at the diagnosis, we find out that most of our patients, they don't have money to buy drugs. Please, once we do full blood count ESR analysis and you know that you won't own the final management, kindly send the patient to the rheumatology unit. And also we discourage steroids. We find out that once there is a joint pain, everyone thinks that once I give steroid, the child will be better. But the issue is this. What if the joint pain or the joint swelling is due to a lymphoproliferative disorder? Once we start steroid, even if they do a BMA, they will not see the blast again. So we always say that we should not be in a hurry to start steroid. So impact of delayed diagnosis when we talk about PRDs, joint damage. Patient can be completely, we have them a lot in the clinic. They're unable to chew, the temporomandibular joint involvement. They're unable to turn their neck because of cervical joint involvement. They are unable to lift up their hand because the elbows, there's already contracture of the elbows. The fingers too, they cannot write in class anymore. So we have to ensure that once we come across these children, we should refer them on time. Also, growth failure. They will look stunted because of the disease, and also sometimes because of our medications. Most of them are on steroids. Then organ complications, especially the kidneys, is usually very, very very expensive for the family. Then also psychosocial burden on the family and on the patients. So summary, children do get rheumatic diseases too. Early recognition can lead to better outcome, though we have said that they are chronic diseases, but when they present early, their quality of life is good. There are so many children now that when you see them, if they do not tell you that they have a rheumatic disease, you wouldn't know because they are living a normal life. They presented early, parents are able to pay for their investigations and medications, and they are fine. So we shouldn't ignore persistent joint symptoms in a child. It could be anything. We've seen a child with just joint pain that came to the clinic, but I was even rounding up the discussion and I just felt, okay, because she's a girl, Mommy, can you pay for serology? She said yes. It was actually a case of lupus. No skin rash, no arthritis, no alopecia, no pallor, just joint pain. And it was actually a case of lupus. So we should not ignore persistent joint symptoms in a child, especially if that child is a girl. Musculoskeletal pain is not the same as arthritis. That the child has pain, joint pain, doesn't mean the child already has a JIA. Once the diagnosis is unclear, once we have any patient that we don't know what is wrong with the child, please let us refer to the rheumatology unit. Then we should never be in a hurry to start steroid. Thank you for your attention.
Thank you very much, Dr. Faleyema, for this presentation. It was really an eye-opener. And one of the lessons I took from here is that the clinical features of rheumatic disease could be anything, and so our index of suspicion is required. Okay, at this juncture, we will entertain questions from our participants. Let me look into the chat box if we have questions there. Okay, no questions there on the chat box. If we have questions, can we signify by raising our hand so that we could unmute and ask our questions? I can't, okay. Okay, Dr. Ogunlaja, you have the floor. You can go ahead to ask your question. Thank you.
Good afternoon, everybody. Network kicked me out before I got that part. So she was talking about the serology, and I think the last thing I heard I was kicked out is that you shouldn't request for serological investigation. So, or she can just help me clarify that part so that I can have a clear understanding on that aspect. Thank you very much.
Thank you too.
For your question, let me look into the chat box. No question yet. Let me see. Okay, Professor Nikema, you can go ahead, ma, to ask your questions. Prof, ma. Professor
Prof, you have the floor, ma. You can unmute and speak, ma.
Right. I had actually started asking my question, but I was not unmuted. Thank you very much, Dr. Faleye. I think it's Faleye, yes? Ayodele Faleye.
Thank you.
Yes, well done. You've definitely done a big job to remind us of the intrigues of how joint pains present. I believe that, there must be some latest discoveries about this, because what you told us, quite frankly, I remember from the old days that was exactly how we learned about joint pains. What about the genetics? What about, what have they found about the causes? Any nutritional, genetic, are there some causes that can be looked into and prevented now? That is my own concern. I believe that, because of the terrible outcomes of this joint inflammation, there must be something that we can look into to prevent them. As we know, inflammation in the body is being studied now very, very thoroughly. And people have thought about various things that are causing it. So just, let us into that area a little bit. Thank you.
Thank you, ma.
For the question. Dr. Faleye, I think you can go ahead to start answering the questions. Thank you, ma.
Okay. Thank you for the questions. Thank you. I'll start with the first one on the why I was saying that we shouldn't request for serology. We notice that sometimes when patients come to, or when patients are referred to the rheumatology clinic, the doctor would have done a lot of investigations, including serologies. Now, we don't run all autoantibodies on all patients with suspected rheumatic diseases. The type of serology that we request for will depend on our clinical findings. So there was a time we had a patient that was asked, had joint pain, just joint pain, no joint swelling. And then we found out that they asked the patient to do anti-nuclear antibody, rheumatoid factor, anti-CCP, C-ANCA, P-ANCA. We are only going to write maybe C-ANCA, P-ANCA, we are seeing a type of vasculitis. It's not necessary in that patient. Number two, this patient doesn't even have any joint swelling to suspect juvenile idiopathic arthritis or any of the connective tissue disorders when we clapped the father. It was actually a case of a girl with joint hypermobility and flat feet. So at the end of the day, the investigations, they were not needed. Ordinary full blood count, ESR, and urinalysis would have been enough or would have been okay. Now, we have other cases whereby the family, they have financial constraints. Before coming to us, they will have done a lot of investigations. When they now come to us and we feel, okay, oh, this is the diagnosis, they don't have enough money for what we want them to do and for the medications to treat the child. So most times we usually discourage having serology done before we see the patient because they may not even need what you have written for them to do. And these serology investigations, they are very expensive. It takes 2 weeks for them to have the results. So we think that is a waste of time and resources for the patient. And at the end of the day, most of the results, they do not lead us to the definitive diagnosis. So that is why we are discouraging that. Thank you, Prof, for your question. Yes, thank you for latest discovery about pediatric rheumatic diseases. Yes, there have been genetic studies. Some have done some on the APO1 gene, which is known as a poor prognostic factor for lupus nephritis, but not in Nigeria. I know they did in Ghana and in some other countries. Then also we have found that certain individuals, they have some type of complement deficiency that can predispose them to lupus. Then also the issue of there's an association between lupus and major HLA. Yes, there's a relationship between lupus and HLA. These are some of the genetics that has been linked, and there are some other ones with some other diseases. Now, in our own country, we have not started genetic studies. I know, I work closely with the adult rheumatologists. I have not even started genetic analysis on their patients. What are the risk factors for all this in a Nigerian, whether an adult or a child? This has not been established. You mentioned nutrition, Ma. I don't know. We've not linked nutritional issues with most of these connective tissue disorders, especially in children. It's been documented that they have been genetically predetermined. But when there is a trigger, like exposure to viruses, some of them do develop connective tissue disorders after a viral infection. And that's why we ask that question, that, okay, before the development of this joint pain, did you have any cough, catarrh, anything suggestive of upper respiratory tract infection, yes or no? Just to know, because some viruses have been implicated, especially Epstein-Barr virus. It's been associated with lupus and some of the autoimmune diseases. So that is also a risk factor. Exposure to some chemical agents too. Some will say exposure to benzene and some others. But in literature, has been genetically predisposed. One has been genetically predisposed that one can now develop this. Not because all of us do have viral infection, but we have not come down with autoimmune disease. Then also another very important one that I need to mention is the COVID pandemic. Then we had so many people that were diagnosed with connective tissue diseases, especially during COVID and after COVID. Most people that had COVID, they later came down with connective tissue disorders. Probably there was a genetic predisposition before the pandemic, and now they came down with the disease. Hope I've been able to answer your question, Ma.
That's excellent. But let me just say that
Yes,
my source of interest here is that when you get to old age, you begin to suffer all sorts of joint pains and muscle pain and all that. And I was just wondering, could this also be related to what might have happened in childhood, which was missed? So that's another angle to it, which I thought you should, probably enlighten us on or look into if you are not already, familiar with it. Okay. Thank you.
yes. Thank you, Ma. Thank you for that. But for old age, we usually talk about wear and tear, osteoarthritis, joint pain. Sometimes it's swollen, it gets better, and that is in the elderly. But when we talk about autoimmune diseases, if it was present, if the individual had it when he or she was young, and then the individual is still living up to now without medications, I don't think it is possible, Ma. The health-related quality of life will have been poor, and so many other complications would have occurred along the line. So for old age, we talk more about osteoarthritis of the wrist, of the knees, of the wrist, of the knees, of the ankles. All these are possibilities. And also I remember cervical spondylosis, lumbar spondylosis. All these can occur, especially because just as we are aging, most of the joints too, they are aging, and so we can have musculoskeletal symptoms.
Thank you so much. Just
Yes.
to remind us of the second childhood season. Thank you.
Thank you, Ma.
Right.
Thank you, Ma.
Right.
Alayema. There are two more questions on the chat box. I think we should answer that quickly before we round off the discussion for today. There's a question, as a follow-up question, is it safe to say when ESR is normal, no need for further serological investigation? Then the second question is also directed to you. Says some of our patients would prefer not to come to LASUT. Where do you consult privately?
So that one, let me answer that one. I will
That's a
share
private conversation.
So, Dr. Yemi, I will share, I will talk to you privately. Is that okay, Dr. Yemi? I will do that. I'll connect with Dr. Falaye. Thank you.
Yeah,
Go ahead and
thank you,
answer.
sir. Yeah, thank you, everyone. I like the question of ESR being normal. Do we need to do serology? Yeah, because I was not asked to talk on I didn't, not that I was asked, I chose this topic because I just wanted to give a general overview. Assuming my topic was juvenile idiopathic arthritis, and I have 45 minutes to talk, I would have mentioned some of the investigations. Now, we do not need any investigation to diagnose JIA, both oligoarticular and polyarticular. Is a clinical diagnosis. They walk to the clinic, usually the ESR. Sometimes, don't let me say usually, sometimes their ESR is even normal. Full blood count is normal. But they will give history of joint pain, joint swelling that has lasted for more than 6 weeks, and it will be obvious that disability is setting in. We don't need any investigation to further prove that. But why do we do full blood count ESR in those group of children? We do it because we want to place them on medications. We know that we need some of the medications can cause leukocytosis, neutrophilia, like steroid can cause that. You need to monitor them. Then also the ESR, not necessarily, you want to check vital organs too. Hope they are okay. They are able to metabolize the drugs that you want to place the child on. That is why we do investigations on them. So we may not necessarily do serology. Let me give you another example. I have had up to 3 cases of lupus, and these parents, they do not have money for serology. But I was able to say that this is lupus because they came with key features. They had alopecia, malar rash, they were pale. We transfused them 4-5 times. We did urinalysis. We had a massive proteinuria. We had hematuria. What else do we want? So they don't have money, but we have to save a life. We commenced medications. It was after 6 months to 1 year that they had money and they went for the serology. They brought back the results. It was actually lupus. But assuming we did not start at that point, we will have lost the patients. So sometimes it depends on the situation. If ESR is normal, if you are thinking of oligoarticular JIA or something, you don't need serology. What you need serology for, another thing we should know is that when anti-nuclear antibody is positive in oligoarticular JIA, they are at risk of uveitis, blindness. When ANA is positive in a child that has presented with just two joints that are inflamed, let's say the bilateral knee swelling, and you have anti-nuclear antibody positivity, that's a child that should visit the ophthalmologist at least every 3 months to be so sure that he or she does not have uveitis or did not develop uveitis in the course of the management, which is a possibility. So those are the reasons why we say, okay, let's do serology. Then for polyarticular, if it's rheumatoid factor positive, you know that patient will live with that disease. That patient will will go through transition. But if it is rheumatoid factor negative, most times they can outgrow the disease. So it's just to, prognosticate, not to help you in managing that patient or in diagnosing the patient or anything. Just to be able to tell the patient you have a severe aggressive disease, you are likely to live with it, or your disease is not very aggressive, you may outgrow it. So there are so many reasons why we write serology. And that is why we are saying, please, before you refer to us, don't write any of the autoantibodies for the patients. Let's see them first. Then we take our decision.
Thank you very much, Ma, for this eye-opening presentation. I'm sure the participants enjoyed the discussion this afternoon. Thank you so much, Ma, for your time. Dr. Dushote, sir, I'm handing over to you, sir.
Thank you, Dr. Faleye, once again, Dr. Okoro, rather, for facilitating this meeting. So I hand over to Dr. Etu for his closing remarks before we round up the meeting. Thank you.
Okay, thank you very much, Dr. Dushote. On behalf of the Guild, again, I want to thank Dr. Ayodele Faleye for giving us a very stimulating diet today. And be rest assured that we'll call on you to give us a talk on juvenile idiopathic arthritis. I hope I got that right. So that will be part 2 of this presentation, because I think we need to know about a little more about that and other things that you manage. And Dr. Dushote will reach out to Dr. Yemi, my good friend, about the other question he has asked. So again, I want to thank everybody who has been online, particularly Professor Adenike Grinch, who's called in all the way from America. So for the young ones, don't think that it's only the young ones who are ready to learn. Mama is also here to encourage all of us. And you can hear from the kind of questions she's asking that we all need to participate actively at webinars like this. I also want to thank Emeritus President, our first President, Dr. Balaji Lawal, who is also on the call, and Dr. Oshodipo, who is called all the way from the UK as well, and every other person who is here. I say a big thank you to you. Without you, obviously, these webinars will be meaningless. So we look forward to seeing you again next month when we have another interesting topic. Thank you very much, Dr. Dushote. I hand over to you. Hello, Tule, can you hear me?
Welcome.
It looks as if we've lost Dr. Dushote. So, well, on behalf of Dr. Dushote, I say thank you to all of you and have a wonderful evening. Thank you. Bye-bye.
Yeah. Thank you, sir. Thank you, sir.